Welcome to this introductory webinar about the UroDapter. My name is Bela Koves. I'm an academic urologist and the Chief Medical Officer at UroSystem. The aim of this webinar is to provide a comprehensive summary of the use of UroDapter for medical professionals, distributors, or interested patients. The webinar is structured into 4 chapters. We begin with the fundamentals. What is the UroDapter and what are the principles behind this innovation? In the second chapter, we continue with a very practical visual overview of how the UroDapter works. Following that, we cover the most important medical indications where the UroDapter can be used. And finally, the fourth chapter addresses frequently asked questions regarding the use of UroDapter. So, what is the UroDapter? There are different diseases or medical conditions where doctors give some medications or drugs directly in the bladder. This approach is called intravesical instillation or intravesical drug delivery. Traditionally, we used standard urethral catheters to deliver such intravesical instillations. However, catheters were never designed for this purpose. The main indication of urethral catheters is to drain the urine from patients, either because they have an obstruction, like it happens sometimes in elderly men, or they are in no physical condition to spontaneously empty their bladder. And for this purpose, catheters are well designed and a necessary choice. But for intravesical instillations, in patients who are capable of spontaneous healthy voiding, there is just no need to push a catheter, basically a rigid tube, through their urethra, and the only reason we used catheters was the lack of a better alternative. So, what are the problems with catheterization? When we insert a catheter, there is always a chance to cause urethral lesions or microtrauma, which can lead to urethral strictures in the long term or cause bleeding in the short term. With catheters, we can transmit uropathogenic bacteria in the urinary tract, leading to symptomatic urinary tract infections. And from the patient's perspective, catheterization is an unpleasant, often painful experience. And even if the catheterization is not painful, there is always the psychological distress before the procedure, the fear from the pain, which is often worse than the procedure itself. So, what could we do to solve these issues? The solution is the UroDapter, a urological syringe adapter designed to deliver intravesical or urethral instillations without a catheter in both male and female patients. With UroDapter, we can avoid causing urethral strictures, there is significantly less bleeding and infections, and the installation becomes completely painless. Therefore, patients will experience no fear before installations. Furthermore, it's an easy and quick procedure and allows the simultaneous treatment of both the bladder and the urethra, which is not possible with a standard catheter. The UroDapter is a CE-approved, FDA-registered Class 1 medical device. It has 4 main parts. A short, rounded tip. This is the only part entering the urethra to a depth of only 6 to 8 millimeters. Then there is an isolating collar that creates a watertight seal and closure around the urethral orifice, ensuring a leakage-free installation. This is followed by a ribbed handling grip for easy manipulation and a connecting tail that is compatible with both Luer slip and Luer lock syringes. In the second chapter, we will review how to use the UroDapter in female and male patients. There are a few things to do before starting the installation. In case of a new patient, we should check that the patient doesn't have a significant post-void residual urine in her or his bladder. This can ideally be done with an ultrasound after urination. If we do not have access to an ultrasound, residual urine can also be checked using a single-use catheter. Ruling out significant post-void residual urine is only necessary once as an initial step, and doesn't have to be repeated before every instillation. Therefore, once we have ensured that the patient doesn't have residual urine, we can simply ask them to empty their bladder to the toilet before instillations. We should attach the UroDapter to the syringe filled with the medical solution we want to instill, and finally, we should properly disinfect the urethral orifice. And with this, we are ready to start the instillation. To easily understand the instillation process, we will use some animation videos, starting with female patients. And you can also find these videos and the detailed step-by-step instructions and guide at the app.urodapter.com website. First, we need to make sure that we have a visual access to the urethral orifice. In case we are right-handed, we can use the fingers of our left hand to achieve this. And we can also gently position the urethral orifice a bit downwards under the symphysis toward the rectum. And this is important because if we try to push anything to the urethra, let's say the UroDapter, a catheter, or an endoscopic device, just straight forward, then we might reach and push to the symphysis of the pubic bone. And this is, of course, unpleasant to women. And furthermore, it also blocks the free flow of the instilled solution. Then, for the same purpose, as we insert the UroDapter in the orifice, we gently drive the syringe with a spooning motion under the symphysis. Doctors or practitioners performing regular female catheterization or cystoscopy are familiar with this spooning motion, as this is necessary to bypass the pelvic bone. After the spooning motion, the UroDapter and the syringe should be parallel with the urethra. This optimal angle will cause the least resistance and easy flow of the solution while pressing the syringe. However, the proper angle to get parallel with the urethra might be depending on the pelvic anatomy of the patient, which typically relates to the patient's age. As a general rule, for younger patients, the optimal angle might be a bit upwards, meaning that the tip of the UroDapter is situated slightly above the syringe, whereas for older patients, it might be a bit downwards. It is important to ask the patient to relax her pelvic muscles. The urethral sphincter must be relaxed to let the solution easily flow into the bladder. The UroDapter must be positioned in the urethral orifice with the necessary force to provide a watertight closure of the urethra and avoid leakage. Inexperienced users might be afraid from this and might try to use the device without the necessary subtle but firm force. But this will result only in an inadequate closure of the urethra and possible leakage. Therefore, correct positioning of the UroDapter is very important. Use the spooning motion to get under the symphysis, adjust the angle to be parallel with the urethra, and press the device firm to the urethral orifice to provide watertight closure and avoid leakage. After positioning the device, we can start the instillation by slowly pressing the syringe. In case we position the UroDapter correctly, we should be able to instill the liquid without applying heavy force to the syringe or feeling a major resistance. Of course, there is a chance that our initial positioning was not ideal and we didn't find the optimal angle. Therefore, once we begin to slowly instill the liquid, we should always adjust the angle of the UroDapter and the syringe until we feel that the fluid flows through the urethra with the least resistance. During proper instillation, the instilled solution will increase the intraurethral pressure above the sphincter pressure and will completely open the already relaxed sphincter, allowing the solution to easily flow into the bladder. This amount of pressure in the urethra is very similar to the pressure we create during spontaneous urination and doesn't cause any harm, damage, or problem. If you feel that the patient is tense or anxious and cannot relax her sphincter during instillation, just slow down or pause the instillation. Instruct the patient to take a few deep breaths and relax her pelvic muscles and sphincter. Resume only when the patient relaxed her sphincter. Remember, during proper instillation, the instilled solution will flow through the urethra easily without any major resistance. After the instillation, simply remove the device from the urethra. Some minimal, insignificant leakage may occur after the instillation, but it's usually just a few drops. And with this, we completed the instillation process with UroDapter in female patients. In male patients, the instillation with UroDapter is very similar to female patients, with a few important differences. The first step is also the correct positioning of the device in the urethral orifice, providing watertight closure. In male patients, it is very easy to position the UroDapter and the syringe parallel with the urethra. By starting the instillation at low speed, we should feel the solution flow through the urethra without any major resistance. Just like in female patients, during proper instillation, the instilled solution will increase the intraurethral pressure above the sphincter pressure and will completely open the already relaxed sphincter, allowing the solution to easily flow into the bladder. The amount of pressure in the urethra during instillation is very similar to the intraurethral pressure during spontaneous urination and does not cause any problem. Slow down or pause the instillation if the sphincter is still constricted. Instruct the patient to take a few deep breaths and relax his pelvic muscles and sphincter. Resume only when the patient relaxed his sphincter. A very important difference between female and male patients is that the male urethra is much longer below the sphincter. This means that by simply instilling the liquid from the syringe, a significant portion of the instilled solution remains in the urethra, which would be lost after removing the UroDapter. To avoid this and to deliver the whole amount of drug solution in the bladder, the two-step process must be followed in each male patient. After complete instillation of the solution, compress the urethra below the orifice by 2 fingers and remove the syringe with the UroDapter from the orifice. While keeping the compression of the urethra, fill up the syringe with 20 ml of air. Reinsert the syringe with the UroDapter into the still compressed orifice and ensure its complete sealing by the isolating collar. Release the urethral compression and push the air slowly into the urethra. The instilled air bubble will push the remaining liquid into the bladder. This small amount of instilled air is completely harmless and will be emptied with the first urination after the instillation. Please remember, you can find these video animations and the detailed step-by-step instructions at the app.urodapter.com website. In the third chapter of the webinar, we will review the most important indications and medical areas where the UroDapter can be used. This figure shows the different medical areas where intravesical instillations are used in medicine, like ganglion deficiency, radiology, or uro-oncology. Overactive bladder represents the group of diseases where intravesical treatment is currently not a general practice, but has potential in the future. And there are other areas where intravesical instillations are used sporadically or based on local, regional traditions. In most cases, intravesical instillations are used for therapeutic purposes, but in radiology, for example, instillations are part of the diagnostic routine. And in each medical areas, we can also define the different specified diseases or medical conditions where intravesical instillations have an important role. And finally, there are different medical products or solutions practitioners want to instill in the bladder in all these different medical areas. Let's start with ganglion deficiency. The glycosaminoglycan or ganglion is a very thin layer on the inner side of our urinary bladder. We can think of the urinary tract as part of our body's waste disposal system. Therefore, many irritative elements are excreted in our urine, which is stored in our bladder. Ions like potassium from different foods and drinks, caffeine, nicotine, alcohol, spices, and so on. We all would have constant urinary painful irritation if our receptors in our bladder wall would not be protected against these irritative elements. The main role of the glycosaminoglycan or gag layer is to protect the bladder wall from these irritative substrates and also from the attachment of bacteria. The gag layer consists of different elements like hyaluronic acid, chondroitin or heparin sulfate. This is why most medical products for gag layer replenishment contains one or more of these substrates. The gag layer can be damaged or weakened for different reasons. Patients suffering from interstitial cystitis or bladder pain syndrome have a primary gag layer deficiency. This means that they do not need an external trigger or damage to have a weak gag layer, like if somebody has a sensitive skin and is easily getting sunburn or has an eczema causing skin irritation. Because of their weak gag layer, these patients have chronic irritative, often painful urinary symptoms caused by their own urine, and in most cases need lifelong treatment. There are different treatment options for these patients, including diet and some oral treatments. But a very important part of their treatment plan is intravesical instillation of gag layer regenerative solutions. These are typically weekly instillation treatments for 4 to 6 weeks, and many patients get long-term further instillations for many months or even years. Because of the need of multiple and chronic instillations, the UroDapter is ideal for these patients. In the following conditions, like recurrent urinary tract infections, the gag layer has a secondary deficiency. Urinary tract infections, or UTIs, are among the most common types of infections, affecting over half of all women during their lifetime, usually manifesting as bacterial bladder infections or bacterial cystitis. While these infections are typically sporadic, single infectious episodes, many women suffer from recurrent cystitis. This means that these women have recurring bacterial infections, often associated with sexual intercourse or other risk factors. During these infections, patients suffer from lower abdominal pain, frequent and painful urination, very similarly to those patients suffering from bladder pain syndrome. There are many different risk factors which make women susceptible to recurrent urinary tract infections, like low fluid intake, hormonal status, or sexual activity. And since the gag layer has an important antibacterial barrier function, having a weak gag layer is one of the risk factors for recurrent UTI. The repeated bladder infections then further weaken the gag layer, creating a vicious circle. While in case of a sporadic cystitis, an oral antibiotic course is sufficient, in case of recurrent urinary tract infections, doctors need to focus on preventing further infections. There are many different elements of this prevention strategy, like cranberry or boosting the immune system. Regenerating the gag layer with intravesical instillations is an important part of this strategy. Intravesical gag layer regeneration is a relatively newer approach in this indication. It became listed in international guidelines as a recommended option a few years ago. And for these patients, UroDapter is an ideal choice as well. The gag layer of the bladder might be weakened due to different oncological treatments as well, such as irradiation or chemotherapy. Pelvic irradiation is used for various cancer types in both sexes. During pelvic irradiation, the bladder often becomes affected and irradiated, leading to an irradiation-induced bladder inflammation and gag layer deficiency, known as post-irradiation cystitis. It is estimated that around 5–10% of patients undergoing pelvic irradiation develop post-irradiation cystitis. And As you can see in this cystoscopic image, the irradiated bladder wall can be highly inflamed and hypervascularized, resulting in spontaneous severe bleeding from the bladder. Hence, post-irradiation cystitis is often referred to as hemorrhagic cystitis as well. And in case of severe bleeding from the bladder, which typically occurs if there is a localized bleeding tumor in the bladder, urologists might need to perform transurethral endoscopic surgery to stop the bleeding. And while this is relatively simple in case of a bladder tumor, where the bleeding is localized to a smaller area, the surgery might become extremely challenging in the case of hemorrhagic cystitis, where the entire bladder wall is affected and often the surgical procedure itself triggers new bleeding areas. Therefore, treating post-irradiation or hemorrhagic cystitis and preventing the need for surgery is very beneficial for both the patients and their doctors, urologists or oncologists. And intravesical gag layer regeneration therapy is one of the most effective methods to treat post-irradiation cystitis. Once intravesical instillations have been indicated, there is an additional benefit of UroDapter in this patient group. Due to the condition of the bladder wall, catheterization has a high risk of causing bleeding during instillations. Therefore, performing intravesical instillations with the UroDapter is highly beneficial for both the patient and the therapist. Post-chemotherapy cystitis is a condition very similar to post-irradiation cystitis. When patients undergo systemic chemotherapy for various types of cancer, cytotoxic chemotherapeutic agents are cleared out through the urine and stored in the bladder, and this may cause strong chemical irritation, inflammation, and chemically induced gag layer deficiency. Due to the strong inflammation and damage to the bladder wall, the chance of spontaneous bleeding is high also in post-chemotherapy cystitis. Therefore, it is also often referred to as hemorrhagic cystitis. And the same challenge with transurethral surgeries exists in the case of post-chemotherapy cystitis. It's preferable to avoid a surgical approach to stop the bleeding. Intravesical gag layer regeneration is highly effective in treating post-chemotherapy cystitis, and avoiding catheterization and the increased risk of catheter-associated bleeding is a crucial consideration here as well. Therefore, performing intravesical instillations with the UroDapter is highly beneficial for both the patient and the therapist. After discussing the various medical conditions associated with gag layer deficiency, let's see how the UroDapter can be utilized in uroradiology. Radiologists use contrast agents to fill the urethra and sometimes the bladder and make them visible on X-ray images or during real-time X-ray imaging known as fluoroscopy. This method of filling the urethra with a contrast agent is called ureterography or cystography if the bladder is also filled. Radiologists or urologists perform uretero and cystography for various reasons. In traumatology, it is mandatory to perform ureterography before inserting a urethral catheter in case there is suspicion of urethral trauma. Inserting a catheter into a damaged urethra can make the urethral damage significantly worse. You can see as the contrast agent leaks from the injured urethra on the image. Ureterographies are widely used in urology to diagnose urethral strictures, to identify the localization and the length of the stricture, as shown in the picture. And finally, ureterography can be useful for diagnosing urethral diverticula, small pouches of the female urethra. Ureterographies are traditionally performed using standard urethral catheters, but only the first few centimeters are inserted in the urethra. Now, this is a clear situation where the catheter is used only due to the lack of a better alternative. The UroDapter is the ideal device for uretero and cystographies.
In uro-oncology, intravesical instillations are widely used for treating superficial bladder cancers. These types of bladder cancers can typically be managed with transurethral endoscopic surgery. After the surgery, many patients receive intravesical treatments with chemo or immunotherapeutic agents, such as mitomycin, epirubicin, or BCG. These treatments can last from a single instillation to several weeks and represent a very common and widespread method of intravesical drug delivery. An important consideration in this indication is, however, that these are irritative or cytotoxic drugs, which typically require special handling and waste disposal protocols. Therefore, unnecessary skin contact should be avoided with them. There is very limited data available on the use of UroDapter in this indication. However, the risk of leakage should be considered, and the use of UroDapter should be recommended only by experienced users. When we talk about the use of UroDapter related to different oncological indications, there is room for some possible confusion. Therefore, I would like to quickly show the ganglion deficiency group again. Please note that in the ganglion deficiency group, we previously discussed post-irradiation and post-chemotherapy cystitis. These are secondary bladder conditions resulting from unrelated oncological treatments. The aim of intravesical instillations here is to treat these post-oncological treatment conditions with ganglion regenerating drugs. On the other hand, in uro-oncology, intravesical instillations are applied as part of the oncological treatment to treat the cancer itself using chemo or immunotherapeutic agents.
Overactive bladder represents conditions where intravesical instillations are not currently standard practice, but they might become an important area in the future. Patients with overactive bladder or OAB have a highly sensitive bladder, which causes a strong, sudden urge or need to urinate that is difficult to delay. Unlike normal bladder filling sensations that gradually intensify, these patients experience their urge of urination very suddenly and very strong. In severe cases, patients may need to cease activities abruptly to seek a restroom or toilet, such as stopping mid-shopping in a mall. Therefore, this disease has a very strong negative impact on the quality of life of these patients. Currently, most cases of OAB cannot be cured. The goal of the treatment is to reduce symptoms with oral medications. However, these medications often have significant side effects, such as dry mouth or eyes, constipations, dizziness, or headaches. Due to these side effects, scientific research projects investigated the possibility of direct intravesical treatment for overactive bladder, with very positive results. Intravesical symptomatic treatment of OAB has been shown to be effective and without side effects. The main limitation, however, of intravesical treatment currently is the need of repeated, regular, long-term administrations by medical personnel. Nevertheless, intravesical instillations are already being used successfully in clinical practice for overactive bladder in some countries and in some centers. And if patients can learn to apply intravesical self-treatment with the use of UroDapter, this approach could become widespread in the future. Finally, intravesical instillations are used for various indications locally by different practitioners. These indications are typically not based on the recommendations of international guidelines. They can be considered more a part of local or regional traditional treatment, or simply methods employed by individual clinicians. For instance, some clinicians administer intravesical antibiotics to treat or to prevent urinary tract infections. Another example is the use of bacteriophages. Bacteriophages are viruses that destroy bacteria, and phage therapy, which uses bacteriophages to treat human bacterial infections, has a very old tradition in some regions, and intravesical treatment with phages can be a part of that tradition. In this chapter, we reviewed the most common medical areas where intravesical instillations are used in different indications, applied by different specialists, and using different drug solutions. In the fourth and final chapter of the webinar, we will review the most frequently asked questions regarding the use of the UroDapter. A common question from clinicians or patients unfamiliar with the UroDapter is whether it can be used in both male and female patients. And the answer is yes. The UroDapter is designed for use with maximal efficacy in both sexes. The detailed step-by-step instructions and animations for both male and female patients are available on the app.urodapter.com website. What type of syringes can I use the UroDapter with? This is an important question, and to answer it, we need to understand the types of syringes available on the market. There are two main parameters of syringes that are relevant to our discussion. The first is the size of the syringe. Sizes range from 1 milliliter or cc to 100 milliliter or even more. A 100 milliliter syringe is quite large compared to those used for blood sampling or intravenous injections. And typically 20 or 50 milliliter syringes are used for intravesical instillations, and the UroDapter is compatible with all syringe sizes. The second important parameter is the type of the tip. Most syringes have Luer slip or Luer lock tips, which are compatible with standard needles. With Luer slips, the needle can be attached to the syringe simply by pushing or slipping it onto the syringe tip. With Luer locks, the needle's base end must be twisted onto the syringe tip. Luer locks, for example, are used in intravenous cannulas to ensure better stability and a secure connection to the connecting tubes. In some syringes called eccentric, the Luer slip tip is positioned at the edge of the syringe to provide a better positioning for surface veins or artery injections. And the final tip variant is the catheter tip, which is larger than the Luer tips and compatible with catheter or gastrostomy tube connections. These are mainly for flushing or cleaning catheters or tubes and are found on larger syringes, like 100 milliliter or above. The UroDapter is compatible with all Luer slip, Luer lock, and eccentric tip syringes. The only syringe type it is not compatible with is the catheter tip type, which are not typically used for intravesical drug delivery. So in summary, the UroDapter can be used with any syringe size, provided it has a Luer lock or Luer slip tip, with the common sizes being 20 or 50 milliliters. I experienced some leakage of the solution in female patients. Is this normal? User experience indicates that with the correct technique, the incidence of leakage in female patients can quickly drop below 1%, and there is absolutely no leakage in male patients. However, due to the UroDapter's simplicity and logical design, new, inexperienced users who are unfamiliar with the device may attempt to use it without understanding the proper technique. And simply inserting the UroDapter into the urethral opening and pushing the syringe could lead to unsuccessful attempts. Despite its simplicity and ease of use, the UroDapter is a medical device that requires some practice and proper technique for successful application, just like any other medical device. For instance, the insertion of catheters, especially in male patients, requires substantial practice by healthcare professionals.
In many regions, nurses are not even permitted to insert catheters into male patients. So consider this. The success rate of inserting a catheter without any practice or knowledge about the proper technique would be extremely low. Therefore, it is important to emphasize that new users should first understand how to use the UroDapter properly by following the simple instructions and easy steps provided on the app.urodapter.com website. User feedback suggests that in the first few attempts, a 15–20% leakage rate is normal for female patients, and this rate can be quickly and rapidly reduced to 5% after approximately 10 installations and further to 0.5% with some additional practice. Can I use the UroDapter to drain urine from the bladder? No. The UroDapter was designed to replace the catheter in case of bladder instillations, but not for draining the urine from the bladder. Therefore, it's not suitable to replace the catheter for the purpose of urine drainage. There are two questions regarding residual urine that frequently arise. Should I check for residual urine prior to each instillation in a patient? And can I use the UroDapter in case of significant post-void residual urine? Post-void residual urine or post-void residual volume is the amount of urine remaining in the bladder after a voluntary urination. Normally, post-void residual volume is below 50 ml in 90% of the population. A PVR between 50 and 200 ml is considered significant, and anything above 200 ml is classified as urinary retention. In this case, most protocols recommend the placement of a urinary catheter. Now, significant PVR or urinary retention is more prevalent among elderly men or patients with lower urinary tract or neurological disorders. The presence of post-void residual urine is typically assessed with a quick bladder ultrasound after urination. Alternatively, a catheter can be inserted after urination to measure the drained urine. Assessing the presence of residual urine is necessary only at some point before the first instillation. The patient should be instructed to empty their bladder in the toilet, followed by a post-void ultrasound to evaluate any residual urine. For the majority of cases without significant post-void residual volume, the UroDapter can be used without any subsequent PVR checks. Patients are simply advised to empty their bladder in the restroom before each instillation with the UroDapter. In the minority of cases where patients have significant PVR, the UroDapter is not ideal for bladder instillation. However, it can still be effectively used for urethral treatments or diagnostic purposes. And with this, we have reached the end of this introductory webinar. We covered in detail the principles behind the UroDapter, its proper use, the main indications, and we also addressed some of the commonly asked questions regarding the UroDapter. If you have any questions or would like more information, please do not hesitate to contact us at mail@urosystem.com and we will get back to you quickly. Thank you for your attention.